All right. I think in the interest of time, we'll go ahead and get started. Thank you all for being here and for joining this workshop. This is updates in the diagnosis and treatment of adrenal insufficiency. And I am the moderator for the workshop. My name is Allie Kimball, and I am pleased to introduce the workshop speakers. Dr. Melanie Haynes, and she is an assistant professor of medicine at Harvard Medical School and an assistant physician at Mass General Hospital in the neuroendocrine unit. And joined by Dr. Haynes is Karen Liebert, who is a nurse in the neuroendocrine unit. Both Dr. Haynes and Karen are heavily involved in clinical research, but also play an integral role in our neuroendocrine and clinical pituitary tumor clinical center. And we are delighted to hear from them about this topic. Throughout the workshop, if you have any comments or questions, feel free to type them into the chat. And there'll be some times throughout the workshop where we'll pause to take additional questions. And I think without further ado, we'll go ahead and get started.
Thank you so much for the introduction, Dr. Kimball. Can you see my first screen okay?
Yes.
Perfect. All right, welcome everyone. Good afternoon, good evening, good morning, wherever you may be in the world. It's my pleasure to present with you today alongside Karen Liebert, discussing updates in the diagnosis and treatment of adrenal insufficiency. So I wanted to start by discussing in a brief review of the clinical manifestations of adrenal insufficiency. This is important because the signs and symptoms of adrenal insufficiency are often nonspecific, which can lead to delays in the diagnosis. In this figure here, it goes through symptoms and signs of adrenal insufficiency, or AI, that occur throughout multiple organ systems, including the central nervous system, cardiovascular system, hematologic system, electrolytes, neuropsychiatric system, GI, dermatologic, and musculoskeletal. The superscripts that are associated with some of the signs and symptoms pertain to whether they are specific to the glucocorticoid deficiency, the mineralocorticoid deficiency, or adrenal androgen deficiency. So to highlight a few of these things, we know that AI commonly presents with anorexia, weight loss, nausea, salt craving, and dizziness, of which the salt craving and dizziness are more specific to the mineralocorticoid deficiency.
Hey, Kina, you close that door so I don't have to listen to the music.
Oh, I think someone needs to go on to mute. Thank you. In addition, cardiovascular symptoms and signs include hypotension and dehydration, which are also more specific to the mineralocorticoid deficiency of primary AI. AI can also present with anemia, leukocytosis, and eosinophilia. In terms of abnormalities on a chemistry panel, hyponatremia and hyperkalemia are more specific to the mineralocorticoid deficiency of primary AI. However, hyponatremia also can occur in central AI due to the cortisol deficiency, which results in increased CRH secretion, which is an ADH secretagogue. In addition, the lack of cortisol releases cortisol's normal suppression of ADH secretion, thereby resulting in increased ADH and potentially hyponatremia. Neuropsychiatric symptoms include depression, fatigue, and reduced libido, which is a symptom of the DHEA deficiency that is a common component of adrenal insufficiency. Gastrointestinal symptoms include diarrhea, vomiting, and abdominal pain. In terms of dermatologic symptoms, they can include dry skin, hyperpigmentation, which is specific to primary adrenal insufficiency, and which notably will differ widely between individuals and is most conspicuous in areas exposed to light, palmar creases, and mucosal membranes. The loss of pubic and axillary hair, as well as dry skin that can be seen in adrenal insufficiency, is more commonly seen in primary AI, again, because of the DHEA deficiency. Lastly, musculoskeletal systems in AI include myalgia, joint pain, and weakness. In terms of the diagnostic workup, once you have suspected AI and it's in your differential diagnosis, in an acutely or critically ill patient with possible AI, it's important that therapy should be started before a diagnosis is established. So therapy should not be delayed to establish the diagnosis because it is potentially life-threatening. However, if possible, you can draw random cortisol and ACTH level prior to giving glucocorticoids. Stress dose glucocorticoids, which we'll cover in greater depth later in this workshop, include, there's no standard regimen, but you could try an IV hydrocortisone dose of 100 milligrams times 1 and then follow it with 50 milligrams IV Q6. Notably, mineralocorticoids for coverage in primary adrenal insufficiency are not needed if the hydrocortisone dose is greater than 50 milligrams daily, because that dose of hydrocortisone provides adequate mineralocorticoid coverage. In a person who is not acutely ill, the diagnostic workup of AI is a 3-stage process. First, to demonstrate inappropriately low cortisol secretion. Next, to determine whether the AI is ACTH dependent or independent. And third, to seek a treatable cause. So step 1, demonstrating low cortisol. As we know, random serum cortisol levels are rarely useful because of the circadian rhythm of cortisol, in that low levels of serum cortisol in the evening or overnight are normal. However, a morning serum cortisol level may be useful because endogenous cortisol levels should be highest in the morning. An 8 a.m. serum cortisol of less than 3 micrograms per deciliter is therefore diagnostic of adrenal insufficiency, whereas an 8 a.m. cortisol or a random cortisol at any time of greater than or equal to 18 micrograms per deciliter essentially rules out adrenal insufficiency. And morning cortisol levels between 3 and 18 micrograms per deciliter require further testing. However, it's important to note that cortisol concentrations vary according to the assay used, and therefore knowing what assay your lab uses is critical. Old cutoff values, including these values of 3 and 18 micrograms per deciliter, were developed using immunoassays that had high cross-reactivity with non-cortisol steroids, leading to higher cortisol levels. Newer assays are more specific, have less cross-reactivity with non-cortisol steroids, and therefore the cutoff values are lower. For instance, the cortisol value of 18 micrograms per deciliter on the Alexis cortisol 1 assay is equivalent to a cortisol level of 14.6 to 14.7 micrograms per deciliter on the Alexis cortisol 2 assay. If you're not able to diagnose or definitively rule out adrenal insufficiency with a morning cortisol level, you can then proceed to a 250 microgram IV cosentropin stimulation test, in which you measure serum cortisol at baseline, followed by administering 250 micrograms of IV cosentropin, and measuring the serum cortisol level 30 and 60 minutes after the cosentropin. A peak cortisol level of greater than or equal to 18 micrograms per deciliter is normal, but again, check your assay for the appropriate cutoff threshold. The diagnostic caveats of the cosentropin stimulation test are important to understand. The first, and potentially most important, is that the cosentropin stimulation test is not useful in the setting of acute central adrenal insufficiency. This is because the cosentropin stimulation test is testing only the ability of the adrenal glands to respond to cosentropin, and it's not interrogating the entire HPA axis. In cases of acute central adrenal insufficiency, the adrenal glands will still respond to cosentropin because they have not had time to atrophy. And it will not be until at least 6 to 8 weeks after the onset of acute central adrenal insufficiency that a patient would fail a cosentropin stimulation test. In addition, serum cortisol assays cross-react with glucocorticoids except dexamethasone. So the patient needs to hold their glucocorticoids prior to the test. And third is that the diagnosis of adrenal insufficiency in states of corticosteroid binding globulin or CBG excess or deficiency can be tricky, and therefore you need to interpret the cosentropin stimulation test as well as a serum morning cortisol with caution in such states. This is because most of the cortisol found in the circulation is bound to CBG. So states of high CBG, such as pregnancy and oral estrogen use, will be associated with high total cortisol levels. And states of low CBG, such as cirrhosis and critical illness, will be associated with lower total cortisol levels, regardless of the status of the HPA axis. Work by our group has shown that a serum-free cortisol level of 0.9 micrograms per deciliter by liquid chromatography's tandem mass spectroscopy predicted a total cortisol of less than 18 micrograms per deciliter with 98% sensitivity and 91% specificity. So you can consider sending free cortisol levels in addition to total cortisol levels during a cosentropin stimulation test if you're concerned about altered CBG levels in your patient. Once you have made a diagnosis of adrenal insufficiency, the next step is to determine whether it's ACTH dependent or independent. Note that plasma ACTH levels are useful in distinguishing primary versus central AI, but do not determine whether the AI is present. In primary AI, plasma ACTH levels are generally greater than 2 times the upper limit of normal. In contrast, in central AI, plasma ACTH levels may be low or they may be inappropriately normal given the low cortisol levels. And thus there's significant overlap between ACTH levels in central AI and normal controls. In addition, proper specimen collection and handling of the ACTH sample is important. It must be collected on ice and processed immediately. Otherwise, there is degradation in the tube. In addition, blood samples for ACTH should be drawn either before initiating glucocorticoids or at least 24 hours after the last dose of a short-acting glucocorticoid in order to appropriately interpret the result. So let's say you have a patient who's diagnosed with primary AI based on a low cortisol level and an elevated ACTH. I wanted to highlight that before we go through this figure in detail, I wanted to highlight that the most common causes of primary AI are autoimmune AI in adults here and congenital adrenal hyperplasia in children, which is an autosomal recessive disorder, most commonly caused by mutations in the gene encoding 21-hydroxylase. In all patients greater than 6 months of age with a new diagnosis of primary AI, you should check a 21-hydroxylase antibody. However, even if the 21-hydroxylase antibody is negative, autoimmune AI is still the most likely cause in adults, as many patients become antibody negative when the autoimmune destruction has been present for some time. If you have a patient whom you diagnose with autoimmune primary AI, it's important to consider other autoimmune conditions because in up to 2/3 of patients, autoimmune AI can occur in association with other autoimmune conditions, namely autoimmune polyglandular syndrome or APS1 and autoimmune polyglandular syndrome APS2. APS1 is a rare disorder caused by a mutation in an autoimmune regulatory gene, AIRE, that's characterized by mucocutaneous candidiasis, hypoparathyroidism, and autoimmune AI, and it typically presents in childhood and early adolescence. In contrast, APS type 2 is a polygenic disorder that's most frequently diagnosed during adulthood and is associated with other autoimmune conditions, including hypothyroidism, type 1 diabetes, premature ovarian insufficiency, celiac disease, and autoimmune gastritis. If you have checked a 21-hydroxylase antibody and it's negative, you should proceed with an adrenal CT scan to look for the presence of infiltrative disease, adrenal hemorrhage, infections, or malignant tumors as a potential cause of the primary adrenal insufficiency. In infants and selected children and adults, you should obtain a 17-hydroxyprogesterone, again, to rule out or in congenital adrenal hyperplasia, as we discussed at the beginning of this slide. Lastly, I want to highlight adrenal leukodystrophy, which is an X-linked recessive disorder caused by mutations in the ABCD1 gene, which results in defective oxidation of very long-chain fatty acids and thus their accumulation in various tissues. Males can present either during childhood and adulthood, and the adrenal insufficiency can occur either before or after the presentation of the neurologic disease. And the way to screen for adrenal leukodystrophy is with a very long-chain fatty acid sample. So now I'd like to jump into case 1, which is a patient of mine, 48-year-old female with a past medical history of primary hypothyroidism and early menopause, which she reported occurred around age 40, who was admitted with months of anorexia, nausea, weight loss, lightheadedness, and fatigue. In the emergency room, her heart rate was 120, her blood pressure was 80/60, and she had a BMI of 21.6. She was very ill appearing and had hyperpigmentation of her palmar creases. Her labs, as you can see here, were most notable for hyponatremia with a serum sodium of 125. In the emergency room, they gave her intravenous fluids, 100 milligrams of IV hydrocortisone, and broad-spectrum antibiotics. Her past medical history, again, was notable for primary hypothyroidism and early menopause, which she reported occurred at age 40. And her medications were notable only for levothyroxine. Importantly, she had a strong family history of autoimmune disease, including hypothyroidism, Graves' disease, and type 1 diabetes. Once she responded very well to the fluids, stress dose hydrocortisone, and antibiotics, and endocrine was consulted given concern for adrenal insufficiency. Once she was tapered down to a physiologic dose of hydrocortisone, we performed a 250 microgram IV concentropin stimulation test, which probably wasn't necessary given her baseline morning cortisol was undetectable and she only stimulated to 1.1 micrograms per deciliter. At that time, 24 hours after her last dose of glucocorticoids, she had an ACTH level that was very high at 727 picograms per milliliter. So given this diagnosis of primary adrenal insufficiency, as well as her personal and family history of other autoimmune conditions, I just wanted the group to think about what other autoimmune testing you might send at this point, and feel free to put anything into the chat. Or you can speak up too.
There is a question, Melanie, in the question and answer.
Oh, sure.
About the delta, the change in cortisol, and what is considered acceptable, or how might you interpret that or use that data? And also wondering if the use of dexamethasone would affect the delta that you see on a stimulation test.
Yeah, great question. So we don't look at the delta. We really look at the peak cortisol level that in response to the IV concentropin. So a peak cortisol level of 18 on the older immunoassays, or greater than 14.6, 14.7 on some of these newer assays, would rule out adrenal insufficiency, with the caveat that it would not rule out acute central adrenal insufficiency. So we don't actually look at the delta. Any other questions?
I don't.
Are you done here? Close or no close?
I don't see any other questions in the chat.
Okay. Well, so in terms of investigating the cause of her primary AI, a suspicion for autoimmune primary AI was very high. And in fact, she did have a positive 21 hydroxylase antibody. Although it wasn't going to change our clinical management because she had a known diagnosis of primary hypothyroidism and was already on replacement, we did check TPO antibodies, which were positive. And given our concern for autoimmune polyglandular syndrome type 2, we did check antibodies for type 1 diabetes, so the GAD65 and islet cell antibodies, which were negative, antibody for celiac disease, which was negative, and then the parietal cell antibodies for autoimmune gastritis, which was positive. To my knowledge, there are not established clinical guidelines for the screening of other autoimmune conditions in polyglandular autoimmune syndrome type 2. But in this review from European Journal of Endocrinology in 2023, they do recommend repeating the testing every 3 years and considering screening of family members, as 1/2 of cases are familial. It's also important to do functional testing in autoimmune polyglandular syndrome type 2 for these other autoimmune conditions, including hypothyroidism, hypogonadism, and type 1 diabetes as part of the screening process. And just for an interesting radiologic image, so she didn't necessarily need adrenal CT imaging because we had the positive 21-hydroxylase antibody, but she did have a CT of her abdomen at the time of her diagnosis because of her GI presentation. And I've highlighted here in the red box, you can see her left adrenal gland here. And then 7 years later, after the diagnosis of her autoimmune AI, it's significantly atrophied compared to prior. So I just thought that was interesting to note. And then we'll move along to the next section in terms of if you have a patient in whom you diagnose central AI, what is the differential diagnosis? So we all know that the most common cause of central AI is exogenous glucocorticoid use by far. And pituitary adenomas are unlikely, although may still cause AI, but are more commonly a cause of AI if they're larger than 1 centimeter. Pituitary apoplexy, pituitary surgery, or radiation are all causes of central AI, as well as metastatic lesions. Autoimmune hypophysitis, here under the category of infiltrative disease, includes both immune checkpoint inhibitor-induced hypophysitis, as well as lymphocytic hypophysitis, which can be seen in pregnant women or postpartum, both of which can cause isolated central AI in contrast to pituitary tumors, in which the corticotroph axis is typically one of the last anatomical units to be lost. Traumatic brain injury, I wanted to highlight because up to 1/3 of patients with traumatic brain injury do develop chronic pituitary dysfunction, although it's more commonly growth hormone deficiency than ACTH deficiency. Congenital diseases, including mutations in TPIT, which is a transcription factor necessary for differentiation of the corticotroph cell, can also be a cause of neonatal isolated ACTH deficiency. Empty sella syndrome is associated with central AI, and drugs including megestrol acetate, which is used to increase appetite in cancer cachexia, can cause central AI as it has some glucocorticoid activity by binding the glucocorticoid receptor. There was recently a new clinical guideline that was released, a joint clinical guideline by the European Society of Endocrinology and the Endocrine Society on the diagnosis and therapy of glucocorticoid-induced AI. So I wanted to highlight that here and summarize the guidelines with this slide. So glucocorticoid therapy of greater than 3 to 4 weeks duration at a dose greater than a total daily dose equivalent of hydrocortisone 15 milligrams poses a risk of AI. However, the risk of glucocorticoid-induced AI is dependent on the potency of the steroid, the dose, the length of therapy, and an individual's susceptibility. And notably, any route of administration has the potential to suppress the HPA axis, including oral, topical, inhaled, intranasal, and intra-articular administration. In patients who have been on supraphysiologic glucocorticoid therapy for at least 3 to 4 weeks with the goal to discontinue therapy, you can consider switching to a shorter acting glucocorticoid to start the taper. The taper can be faster and in larger decrements if the total daily dose of steroid is high, and then the taper can be slower and in smaller decrements as the physiologic dose is reached. Glucocorticoid withdrawal syndrome can appear as the glucocorticoid dose is tapered and manifests with clinical features that are similar to those of adrenal insufficiency, including arthralgias, myalgias, weakness, and fatigue, except that the patient is actually at or above a physiologic replacement dose of glucocorticoid, so you can feel confident that it's not, in fact, adrenal insufficiency. If symptoms of glucocorticoid withdrawal appear, the glucocorticoid dose can be temporarily increased to the most recently tolerated dose, and the duration of the taper can be lengthened. Once the physiologic glucocorticoid dose is reached, you can check an AM cortisol or perform a 250 microgram IV cosentropin stimulation test. And the recovery of the HPA axis is observed within 2 years in most patients on chronic glucocorticoids, but somewhat frustratingly can take years, many years, over 4 years in some patients in terms of the recovery of the HPA axis. So this is case number 2. It's an 88-year-old man with metastatic melanoma who is presenting with fatigue. He had initiated ipilimumab, which is a monoclonal antibody that inhibits CTLA-4, 5 months ago, which was then stopped 2 months ago due to a mixed response. He then initiated pembrolizumab, which is a monoclonal antibody that inhibits PD-1, about 3 weeks ago. 1 week ago, he developed fatigue, nausea, anorexia, and chills. In the emergency room, he was noted to be tachycardic and hypotensive, for which he was treated with IV fluids, 100 milligrams of IV hydrocortisone, and broad-spectrum antibiotics. His past medical history was notable for metastatic melanoma, as mentioned, primary hypothyroidism, and chronic kidney disease. His current medications include levothyroxine and pembrolizumab. On physical exam, he had a heart rate of 100. His blood pressure was 110/70. He was alert and oriented, but ill-appearing, and had no hyperpigmentation. His laboratory values were notable for hyponatremia with a serum sodium of 123, a TSH that was low at 0.05, and a free T4 in the normal range at 1.7. He had never had a history of hyponatremia and had never had a suppressed TSH before. Once he responded very nicely in terms of hemodynamically and symptom-wise on his regimen of fluids and stress dose steroids and antibiotics. Endocrine was consulted, given concern for adrenal insufficiency. He was tapered to a physiologic glucocorticoid regimen. And then an 8 a.m. cortisol was performed, holding his hydrocortisone that morning. And he had an 8 a.m. cortisol of 2.8 micrograms per deciliter and an ACTH of 15 picograms per milliliter, which was consistent with central adrenal insufficiency. So next I wanted to show his MRIs. And so I wanted the group to think for a second about what you might expect to see on his pituitary MRI, given this new diagnosis of central adrenal insufficiency and his history of metastatic melanoma on immune checkpoint inhibitors.
Feel free to type into the chat or speak up.
So this was his MRI at the time of admission, and this was his MRI 4 weeks prior. And you can see, compared to his prior MRI here on the right, on the left, he had an interval increase in the size of his pituitary gland compared to just 4 weeks ago. Notably, he didn't have a headache that can commonly be seen with immune checkpoint inhibitor-induced hypophysitis, but we felt that this imaging was consistent, as was his clinical presentation and laboratory values with immune checkpoint inhibitor-induced hypophysitis. So in ICI, immune checkpoint inhibitor ICI-induced hypophysitis, is one of the most commonly reported endocrine immune-related adverse events of ICI therapy, notably CTLA-4 and PD-1 or PD-L1 therapy. In contrast to lymphocytic hypophysitis, which is more common in women, ICI-related hypophysitis presents with higher rates in men, with a male to female ratio of 4:1. It is more common with the combination of anti-CTLA-4 and anti-PD-1 therapy with an incidence of 6.4%, and least common in patients who are receiving monotherapy with an anti-PD-1 or anti-PD-L1 inhibitor with an incidence of less than 1%. It can occur to weeks to months after the initial dose of the immune checkpoint inhibitor, although it usually appears in a median time of about 12 weeks after initiation of therapy. The most common symptoms are headache, although headache tends to be less common with the anti-PD-1 therapies, and fatigue. The pituitary MRI may reveal an enlarged pituitary gland, but importantly, normal brain imaging does not rule out hypophysitis, especially if the initial insult was weeks ago and you're just catching the MRI now. The corticotroph and thyrotropic axes are the most commonly affected. And also importantly, treatment of hypophysitis does not typically require drug discontinuation or high-dose steroids, as the hormone deficiency is usually long-term and persistent regardless of treatment. However, patients with very severe compressive symptoms, such as severe headaches or visual field defects or diplopia, may be considered for high-dose glucocorticoids with a rapid taper. But generally, we do not treat the hypophysitis, and instead we treat the resultant pituitary hormone deficiencies. So I'll stop there and ask Dr. Kimball if there's any comments or questions in the chat.
There is a question. Someone commented hypophysitis, which was the
Right.
diagnosis. There was a question from a prior section, just a general question about how long you need to hold a glucocorticoid like prednisone or dexamethasone prior to checking a total cortisol level or prior to doing a court stim or checking an ACTH level.
Yeah. So prednisone, we typically hold for 24 hours. So in our clinical practice, we'll have a patient take their prednisone dose the day before a court stim test, but then hold it. Hold it the morning of the court stim test, do the court stim test in the morning so that they can take their prednisone right after the test is finished. Dexamethasone has a longer half-life, and I don't typically have patients on dexamethasone as a chronic replacement for adrenal insufficiency, which we'll talk about in a little bit. But that would need to probably be held a little bit longer. But of course, you have to be concerned about that in terms of holding it too long. Dr. Kimball, do you have any comments on that in terms of what you do in your practice?
It's a good point. I also don't have that. I maybe have 1 or 2 patients on dexamethasone for chronic glucocorticoid replacement, although it's not ideal, and I'm sure you'll get into it. Historically, I've held it for just 24 hours, but it does last longer, in some patients. So I imagine you may need to hold it up to 48 hours, but being mindful of, the potential risks of that.
Yeah, I mean, I guess the upside is that it's not going to cross-react with the cortisol assay, but if it's still suppressing their endogenous HPA axis and they fail the court stim test, then I guess you have to wonder, is it because there's still some dexamethasone on board? So I think the cleanest thing would be trying to switch patients to a different glucocorticoid prior to doing a court stim test.
And what about patients for whom they may be on hydrocortisone for replacement or for other reasons?
Yeah. So I have my patients on hydrocortisone. I have them take all their hydrocortisone in the morning, the day before the test. But I think some people might do it differently. Dr. Kimball, what do you do?
I usually do something similar, or ask them to omit their afternoon dose the day before the test.
Yeah. So I typically, like, if they're on 10 in the morning and 5 in the afternoon, I would have them take 15 milligrams the morning before the test, nothing the morning of the test, and then bring it with them and take it right after the test, which will need to be done in the morning.
And there's another question in the chat. Could you comment on adrenal insufficiency in the setting of refractory hypotension with a cortisol of 3 to 10?
So, I think that raises a question of, in patients who are, critically ill, their HPA axis should be maximally stimulated. So, in a patient who's like in the ICU with refractory hypotension, I would be concerned about a cortisol of 3 for sure. And I'd want to do a concentropin stimulation test. It would also be interesting clinically, are they responding? Does their blood pressure respond to the stress dose glucocorticoids or not? And if they weren't responding to the stress dose steroids, then I would definitely want to think about other etiologies, because if AI was the cause of their refractory hypotension, then they should be responding to stress dose glucocorticoids. Any other questions?
I don't see any other questions.
Okay, great.
Sorry. One more question.
Sure.
Question about Decenide. I think for we don't really have any patients. Do you have about 1 million? How many patients on Decenide?
No.
I think the question is related to the prior question about how long do you need to hold.
Yeah, I thought Decenide was like a cream.
If Li-Ling Huang, if you want to unmute, feel free to, if you want to clarify your question. Or if not, you can type, or we can come back to it.
Yeah, let's come back to it, give her a chance to respond. Okay, so actually, that discussion was a great segue because the next slide is about treatment once you have established the diagnosis. So from Dr. Miller's talk yesterday, I believe she covered the idea that our understanding of what physiologic glucocorticoid replacement has changed over the years. We now know that physiologic glucocorticoid production in the body is on the order of just 10 milligrams a day. We used to give much higher doses of hydrocortisone and prednisone in patients with AI, but now physiologic hydrocortisone replacement is considered 10 milligrams in the morning and 5 milligrams in the afternoon. When it's given twice a day, the second dose is usually given about 6 to 8 hours after the morning dose. In a rare patient that might be on a TID hydrocortisone regimen, you could give doses in the morning, at lunch, and then in the afternoon. Physiologic prednisone replacement used to be considered 5 milligrams, now considered 4 milligrams. I have some patients who do well on 3 milligrams in the morning. And as we discussed before, dexamethasone is not an ideal glucocorticoid replacement regimen because it is longer acting. So especially for patients in whom you're worried about side effects, which we should all be worried about side effects in all of our patients, but specifically as well, there's not time for the HPA axis to have time to wake up and recover in patients whose adrenal insufficiency might not be permanent. One problem with these regimens is that they do not replicate a physiologic cortisol profile. And physicians and clinicians in Europe do have other options available. And if there's any of our European colleagues in the workshop right now, I would love to hear about your experience with these medications, as we don't have them available in the United States. But in Europe, a once daily dual release hydrocortisone is approved, which is taken in the morning, and it's reported to have a more physiologic cortisol profile by avoiding the peak drug levels, reducing the afternoon evening exposure, and reducing the overall exposure by 20%. In studies, it's been shown to have associated with a significant decrease in waist circumference, hemoglobin A1C, cholesterol, as well as an improvement in quality of life compared to hydrocortisone TID. However, whether this finding is a consequence of the lower overall exposure, again, the exposure is reduced by 20%, or it's related to the pattern of the hydrocortisone release is unclear. In addition, what's not on this slide is that there's also a modified release hydrocortisone that differs by having a delayed and sustained absorption profile. So it's actually taken at nighttime, and it releases hydrocortisone in the early mornings of the early hours of the morning, which provides a more physiologic waking cortisol levels. So do any of the attendees in the workshop have experience with these medications?
There are a few questions, actually. I wonder if anyone does have experience, we'd love to hear from you. Is this a good time, Dr. Haynes, for me to ask a few related questions?
Oh, sure.
So there was clarification about the prior question. So do patients need to hold steroid creams before you check a cortisol?
Oh, that's a great point. So yes, as much as possible. Of course, the absorption of a cream is going to differ, based on how much of your body you're applying it to and people's individual sensitivity. But I do ask my patients to hold all steroids of any kind prior to their cosentropin stimulation test. So whether that's their fluticasone nasal spray, their hydrocortisone cream. Also have to be mindful about patients who get glucocorticoid injections into joints. Those can have systemic absorption that lasts for many weeks. So I always ask my patients about any recent steroid injections as well.
There's an interesting question. Do you use the formula of the patient's body surface area times 8 to 10 as a ballpark to determine someone's physiologic hydrocortisone dose?
Oh, yes. So I don't use that. And I think part of the issue, and maybe I have that actually on my next slide, so just to help answer the question. And I think part of what that question is getting at is that there is a significant range in individual glucocorticoid requirements. And so I think a one size fits all really does a disservice to our patients. There's a range in the degree of patients' glucocorticoid deficiency. There's a range in their variability in their glucocorticoid metabolism. There's differences in glucocorticoid sensitivity. They've actually shown that polymorphisms in the glucocorticoid receptor are associated with some metabolic endpoints in patients taking glucocorticoids. So I think we can, use what I've presented as starting points, but I do have different patients on different doses. And of course, one of the major problems with the treatment of adrenal insufficiency is that, one, we can't recapitulate the body's circadian rhythm of cortisol. And two, we lack a reliable biological or biochemical marker in order to assess the adequacy of glucocorticoid replacement.
There are some other questions that and comments that I might defer to later because I think you'll cover it. But one question is, is there a specific time in which you would use prednisone for glucocorticoid replacement versus hydrocortisone?
Yeah, I tend to use them interchangeably. I mean, so hydrocortisone has some mineralocorticoid coverage, but patients with primary AI are going to need fludrocortisone as well. Prednisone has the benefit of being once daily dosing. But honestly, what I tend to do is let the patient make the decision, and we will cover this in a future case. But sometimes when I have patients who don't feel well on an appropriate physiologic dose of prednisone, I switch them to hydrocortisone and vice versa. So there's a lot we don't understand about, glucocorticoid metabolism and sensitivity to really understand who's going to do best on which glucocorticoid at what dose. And we just have to do trial and error.
Just two more very quick comments. Any role for checking ACTH level while on replacement to assess for over replacement versus adequacy?
Yeah, great question. So monitoring of plasma ACTH levels is not useful. We monitor glucocorticoid replacement really by clinical assessment, as I wrote on this slide, including blood pressure, body weight, energy, of course, trying to look for and avoid any symptoms or signs of iatrogenic Cushing's. In my experience, a few times I've measured serum cortisol for a patient on hydrocortisone when I'm kind of stuck and I'm concerned about a real discrepancy between their daily dose and their symptoms. And I'm only doing that to make sure that they're absorbing it. So rarely that can be useful, but plasma ACTH levels aren't useful. And 24-hour urine-free cortisol levels once someone's on glucocorticoid replacement are also not useful, just because there's so much variability, and there's not a validated reference range once you're on glucocorticoids. Great. So we touched on this briefly already with some of the great questions in the chat, but we do try. We have patients on the safest minimal dose of steroids, physiologic dose possible, because higher glucocorticoid doses are associated with increased morbidity and mortality. In patients with central AI due to non-functioning pituitary adenomas, they've reported increased mortality has been observed in patients receiving daily hydrocortisone equivalent doses of greater than or equal to 30 milligrams. And many of those deaths were cardiovascular, cardiometabolic in nature. In patients with central AI, bone mineral density is inversely correlated with glucocorticoid dose, independent of other osteoporosis risk factors such as age. And also in patients with hypopituitarism, daily hydrocortisone equivalent doses of 20 milligrams or more are associated with an unfavorable metabolic profile, including a greater BMI, waist circumference, total, and LDL cholesterol. So we really avoid higher glucocorticoid doses for that reason. In terms of mineralocorticoid replacement in primary AI, so the standard fludrocortisone dose is 0.1 milligrams daily, although lower doses such as 0.05 milligrams may be sufficient in patients receiving hydrocortisone, as hydrocortisone has some mineralocorticoid activity. In terms of monitoring the fludrocortisone dose, so changes that you make in fludrocortisone, changes in fludrocortisone-mediated changes in volume and blood pressure are only seen after several days or weeks. So the fludrocortisone dose change should be monitored about 2 to 4 weeks after you change the dose. And things to monitor include blood pressure, presence of edema, serum sodium, potassium, and creatinine concentrations, and the plasma renin activity. The plasma renin activity, I actually don't always check, although when you do check it, it should be in the upper normal range. But the issue is that if the plasma renin activity remains elevated, but the patient is otherwise asymptomatic and doesn't have any symptoms of under or over replacement that we'll go through here, you should not be titrating the fludrocortisone dose just to the plasma renin activity. So maybe it can sort of help confirm your suspicion that a patient's under or over replaced, but you shouldn't be titrating fludrocortisone to plasma renin activity alone if someone is otherwise doing well with no symptoms of under or over replacement. So symptoms of under replacement of mineralocorticoid may include sodium loss, intravascular volume depletion, and hyperkalemia. And symptoms of over replacement may include elevated blood pressure, edema, and hypokalemia. So I'll stop there, and then I'll take any questions that Dr. Kimball has, and otherwise then I'm going to pass it over to Karen.
There's a quick question about the plasma renin activity. Do you recommend that the patient lay down for 30 minutes prior to doing the blood test?
Oh, that's a great point. I mean, that is, typically recommended that they're resting. I mean, this is also true in the evaluation of hyperaldosteronism too, that the patient is at rest before you draw. But I think that there's the ideal, and then there's the reality of the situation in a busy lab. So
I was just gonna say, we don't really practically do that.
Yeah.
There's a question, not directly related to this, but I just thought maybe quickly to mention is, what about a patient who has a baseline cortisol that is relatively low, like 5 or 6, and has a normal stimulation result, so stims to the 20s, but still has symptoms of adrenal insufficiency? It's a difficult question, but.
Yeah. So a random cortisol of 5 or 6 can be normal. I suppose if there's any chance that they could have acute central adrenal insufficiency, you would be justified in repeating the court stim in another, 3 months. So that's typically what I've done in patients in whom I have a high pretest probability, although the court stim test is normal. Of course, no test has 100% sensitivity and specificity, so you always need to use your clinical judgment. So I have repeated court stim tests in patients, 3 months later, in whom I remain, in whom my pretest probability remains high.
Thank you. I think we can move along.
Okay, so I will pass this over to Karen now.
Yeah, great. Thank you very much for inviting me. A little nursing voice and a very complicated topic and case slides. So I'm going to start with case number 3, who is a 60-year-old female with primary adrenal insufficiency and osteoporosis who presents for follow-up. Over the past year, she's been to the ER 3 times for nausea, vomiting, lightheadedness, and dizziness. It's unclear what the precipitating events were, but she admits to being late on doubling her dose of hydrocortisone. Her past medical history includes primary AI and osteoporosis. Her medications are hydrocortisone, 10 milligrams and 5 milligrams, fludrocortisone at 0.1 milligrams, zoledronic acid, IM solucortef as needed, calcium carbonate, and cholecalciferol. Past medical history includes autoimmune disease, including hypothyroidism and Graves' disease. Next slide, Melanie. Thanks. Physical exam was essentially normal. She's heart rate was 70, blood pressure was normal, Weight was 200 pounds with a BMI of 33.3. She was well appearing, normal weight distribution with no signs of any lower extremity edema, no stria, no proximal muscle weakness. And our laboratory data was essentially normal as well. So with an essentially normal physical exam and laboratory values at this visit, the key focus mainly of the visit was the re-education about sick day rules and increasing in glucocorticoid doses with in times of sickness. Next slide. So the adrenal sick day rules, the key strategy is for the prevention of adrenal emergencies. And patient education and early response are key things for this to work. In the cases of illness, fever, and antibiotics, we teach patients to double their glucocorticoid replacement doses. So if they're on 15 milligrams of hydrocortisone in the morning and 5 in the afternoon, we'll have them increase it to 30 and 10. And they'll continue that until the resolution of their symptoms, until they feel better. In the case of persistent vomiting, where oral medications aren't staying down, patients are instructed to administer 100 milligrams of hydrocortisone IM with instructions to page the MD and go to the ER. Like, we don't have them do an IM injection and then stay at home. They need to go have further monitoring and assessments. In the cases of major surgery, this considering things like with general anesthesia or trauma or critical illness, I think Melanie already mentioned this before, but the recommended treatment is hydrocortisone, 100 milligrams IV followed by 50 milligrams IV every 6 hours until the patient is actually feeling better and can take PO glucocorticoids at that point. In the case of hypovolemia, the recommended IV is isotonic saline, and that's to help restore the volume deficit and maybe correct any sort of hypertension the patient may be feeling. The critical point, and one of the sort of nursing points of this, is that patients must have some sort of medical alert bracelet or something on their body saying that they're steroid dependent. And it's not only the patient that should be taught what the sick days rules are and taught how to give the IM injections of hydrocortisone, but it's family members and caregivers. If these patients are down and out and they can't muster the energy to actually do an IM injection, then these family members and caregivers should be aware of the rules and trained to assist if there's a potential adrenal emergency. Next slide. So these are just examples of different kind of medical alert tags. The two top middle ones are the ones that are most common, the medical alert bracelet and the necklace. But now they have cool little, watch bands for your smartwatches now. Like, they have jewelry that looks very expensive and stylish. They have more manly type bracelets. I have some patients that have actually purchased seatbelt covers for their car that contain medical information, so the first responders can actually have that information right there and then and not search for any medical alert tags. Some patients have cards that they keep in their wallet, but even with the cards, it's important to have something on their body in case their wallet is left at home, or so that the tags or bracelets or something are important. And lastly, we teach patients to have an adrenal insufficiency kit available. And in that kit contains the extra doses of hydrocortisone or prednisone and the IM injections of the hydrocortisone and all the needles and syringes that go with it. And along with that is instructions how to do the IM injection. So likely it may not be the patient that's actually doing the injection, but a family or a caregiver who maybe hasn't done an injection before. So it's important to have those instructions. Next slide. These are just examples of some patient resources. On the left-hand side is a resource that's taken from the Children's Hospital in Los Angeles about how to actually give the IM injections of hydrocortisone. And what I really liked about it is the colors. I think it's really easy to look at. The pictures are really easy. And it's a 1, 2, 3 step as to how to actually give this injections for families or even patients who haven't given IM injections before. You got to make it simple. You have to make it easy to read and easy to follow along because they're nervous about giving this injection. On the right-hand side is a patient leaflet we use in our clinic. It's taken from the National Institute of Health publication about adrenal insufficiency. And it's just a one-page information sheet about adrenal insufficiency, some signs and symptoms of what to look for in case of adrenal insufficiency, and then how to treat how adrenal insufficiency is treated. A lot of times there's a lot of information these patients are talked to about in a visit, and they walk out of there and they forget everything. So it's nice to have sort of a simple, brief resource to give them. Next slide. Despite all the teaching and everything that we do with these patients to teach them about adrenal insufficiency, about 50% of patients with AI will have at least one adrenal crisis. The most common causes of adrenal crisis are GI infection, other infectious diseases and fever, surgery, as we already talked about. Strenuous physical activity is not something that a lot of patients think about. They usually think about being sick or being in the hospital, and those are cases where you need to increase the dose. But strenuous physical activity does require a bump up in the glucocorticoids. If you're running a marathon, you're hiking up, a really strenuous hike for 6-8 hours of the day, then that would require some additional glucocorticoid bump. Sensation of glucocorticoid replacement is sometimes a cause. A patient forgets to pick up their prescription and they go away for the long weekend, and now they don't have medication available for the 3 days they're away. Psychiatric distress is another one, and as we talked about, accident and trauma. So with that, I think it's really important to, as a nurse, I need to teach patients. I feel strongly about teaching patients. It's about these sick day rules, and once is never enough. We teach patients about these sick day rules every single time we see them, every single time they bring up, they're sick, what did you do with your glucocorticoid doses? And we always ask for what their medical alert, to have them show us our medical alert tag, because that's important in preventing some of these adrenal crises in the patients. And that's it.
Karen, there's a comment and a question. One is that in the case of if IM hydrocortisone is not available, that a patient could give IM dexamethasone in a crisis, although it does not have mineralocorticoid activity. But there was also a related question. How do you advise patients to adjust to increase their glucocorticoids if they're experiencing psychiatric stress or kind of emotional stress, but they're not physically sick?
I think with most adrenal insufficiency, I worry more about them being under replaced than over replaced. So if they feel like this is enough of a stress that it's causing stress on their body, I would suggest to go up on their doses. I think a short course of high dose steroids is safer for the patients than being hypoadrenal and potentially being in an adrenal crisis.
Thank you. One more question. Do we advise patients to routinely take stress dose steroids for physical activity? Not necessarily running a marathon, but going for a run or playing badminton?
I don't think so. Although I just had a patient yesterday she said she swims a mile in really cold water and feels fatigued for many days after doing this. So she's learned to actually take a bump up in her glucocorticoids, but I think that's going to be patient dependent. Normally, like a short run, an hour run doesn't usually require, a bump up in glucocorticoids. But again, that's going to be patient dependent, I think.
Thank you.
Great. Thank you, Karen. I actually did not know about the car seat belt covers, which is now great. I learned something today too. Great. Okay. So I'm just doing a time check here. It's 5:30. We have 2 more cases to go through. So I think we're doing great. So this is case number 4, 46-year-old female with central AI who presents with fatigue in follow-up. She was diagnosed actually in England with central AI of unclear etiology. And, when she saw me, she was already on hydrocortisone, 10 milligrams in the morning, 5 milligrams in the afternoon. I reviewed her records. We did further testing. I couldn't really come up with an etiology of her central AI either, including a normal pituitary MRI. Of note, she did have a history of reactive airways disease, asthma, which was treated with fluticasone for quite a long time. And as we discussed, even inhaled glucocorticoids can cause glucocorticoid-induced AI. So that was my leading hypothesis at the time. But when she came to me on physiologic hydrocortisone replacement, she was really struggling with persistent fatigue, essentially from the moment she woke up in the morning. I mentioned to you her past medical history of reactive airway disease, asthma, and her only medications were her hydrocortisone replacement, and she had previously normal pituitary MRI. I did a basic evaluation for fatigue, which included a normal CBC and CMP, normal TFTs, and a DHEAS level, which was mildly low. So I wanted to ask the group, what would you do in this case? Because there's not always a right answer, and some of this, as we discussed, is trial and error with the patient.
Any ideas from the group?
Okay, so unfortunately, it's not an uncommon problem to have AI and to continue to feel unwell despite adequate glucocorticoid plus minus mineral corticoid replacement in the setting of primary AI. Many patients with AI continue to report fatigue despite adequate treatment, as well as report affective and depressive disorders, both of which are highly prevalent in patients with AI. And in fact, excuse me, 40 to 80% of patients with AI report disruption of their daily life activities owing to the disease. The underlying cause of the impaired quality of life in patients with AI remains to really be fully elucidated, but the effects of the chronic disease in combination with a lack of DHEA, except of course in congenital adrenal hyperplasia, which is associated with elevated DHEA, but the lack of DHEA and epinephrine, which is made by the adrenals, the complexity is associated with non-physiologic glucocorticoid, mineral corticoid replacement, could all contribute to impaired quality of life in these patients. And many practitioners may want to reflexively increase the glucocorticoid dose when a patient with AI reports fatigue, but studies have shown that in addition to the increased morbidity and mortality associated with supraphysiologic chronic glucocorticoid replacement, higher daily hydrocortisone doses have actually been associated with worse quality of life. In women, premenopausal women, such as in my patient, androgen production by the adrenal glands, or the adrenal glands are the major source of androgen production in premenopausal women. And therefore, AI in premenopausal women is invariably associated with androgen deficiency. Some, but not all trials of DHEA supplementation in AI have been shown to improve overall well-being, mood, and libido in women with AI. The benefit, again, is probably larger in premenopausal women than in women after menopause, as there is an age-related decline, a normal age-related decline in DHEAS levels with age. However, meta-analysis of DHEA trials in women with AI really revealed only minor positive effects of DHEA supplementation. And the conclusion of that meta-analysis was that the data were not sufficiently compelling to support the routine use of DHEA. In addition, studies of long-term outcomes of chronic DHEA supplementation have not been done. And data, and these studies are likely not to be done anytime soon because the DHEA is widely available over the counter and via the internet. Therefore, DHEA replacement is not a mandatory part of the standard replacement regimen in patients with AI, but certainly can be considered. And is one of the things I considered with this patient. First, with her, I tried switching her from hydrocortisone to prednisone, and initially she felt like maybe a little bit better, but then continued to struggle with fatigue. So because her DHEA level was low as expected, we did do a trial of a morning dose of 25 to 50 milligrams of DHEA, and then reevaluated 4 to 6 months later. And she did feel like her energy was significantly improved on the supplement. And we monitored her androgen levels and made sure that the DHEA remained in range. We would check the DHEA levels about 24 hours after her last dose. So for her, I do think DHEA helped as maybe changing the glucocorticoid from hydrocortisone to prednisone, but it doesn't always help in everyone. And in my patients whom I tried DHE on, I explained that it's just a trial, and if after a number of months there's no improvement, we stop it. So I'll stop there and ask Dr. Kimball if there's any questions.
No questions, but really, actually one question, but great comments from the group about other things to consider in these patients: depression, sleep apnea, vitamin D deficiency, iron deficiency, other kind of common things that can cause fatigue. So that's great. And there's a question for patients who are on DHEA supplementation, do you check a DHEA level or a DHEAS level?
Oh, great. Yeah, I typically check a DHEAS level. And then regarding the comments of the group, which were all fantastic, I think that also really highlights that, patients with AI can have any other number of diagnoses, and therefore it's important to not necessarily always, say it's because of the AI, although, the data suggests that unfortunately patients with AI do struggle with some of these issues, despite the best care and treatment. Right. So we'll move on to the last topic and the last case, which is AI during pregnancy, which can certainly, the diagnosis and treatment of AI during pregnancy can certainly be very challenging because the nonspecific symptoms of adrenal insufficiency, like nausea, vomiting, fatigue, and dizziness, are also just normal symptoms during pregnancy. Specific causes of AI to consider in pregnancy in terms of moving up or down in terms of your pretest probability. So autoimmune primary AI is likely to be less common during pregnancy due to the immunotolerance of pregnancy. Lymphocytic hypophysitis is going to be more common in pregnancy and can present most commonly in the third trimester or early postpartum with headaches and or vision changes. Hypercoagulability of pregnancy can trigger adrenal thrombosis, adrenal hemorrhage in women with pre-existing thrombophilic conditions. Diagnostic testing in pregnancy for adrenal insufficiency is difficult, given the physiologic hypercortisolemia of pregnancy, which we'll talk about on the next slide. However, if a pregnant woman has a morning cortisol of less than 3 micrograms per deciliter, that is diagnostic of AI, as it would be in a patient who is not pregnant. But essentially, morning cortisol levels somewhere between 3 up to 32 are really, it's unclear. And the issue is that cosyntropin is a category C drug, so we don't typically do cosyntropin stimulation testing in our clinic in patients who are pregnant. So it really requires clinical judgment. And I have treated some of my patients with adrenal insufficiency who are pregnant, or I have treated some of my patients who are pregnant, diagnosed and treated them with adrenal insufficiency without a cosyntropin stimulation test if the testing in my clinical suspicion was otherwise high enough. So in terms of the physiologic hypercortisolemia of pregnancy, so placental CRH here and ACTH start rising at around 7 weeks gestation, and the adrenal glands are hyperresponsive to ACTH in pregnancy. So that is part of the reason why there is hypercortisolemia. In addition, progesterone from the placenta induces a component of cortisol resistance, which is going to reset the HPA axis to a higher level. And it also displaces cortisol from CBG, which further elevates the free cortisol levels. Estrogen also plays a role here too, because as we previously discussed, it increases CBG levels, and it actually also reduces the clearance of cortisol, thus resulting in elevated total cortisol levels. So the sum of all these effects is that the total cortisol concentration is 2 to 3 times higher in pregnancy. And free cortisol levels also increase starting during the second half of pregnancy and into the third trimester. The fetus is largely protected from this hypercortisolemia of pregnancy because cortisol is inactivated to cortisone by placental 11-beta hydroxysteroid dehydrogenase 2, or HSD2. But excessive maternal glucocorticoids can overwhelm the placental 11-beta HSD2. And therefore you have to be cautious about that. And specifically, dexamethasone is not inactivated by this enzyme, and part of the reason why it's dexamethasone is the steroid that's given to for fetal lung development when needed. Postpartum, the free cortisol levels often return to baseline very quickly within a week or so, but because the CBG levels may take months to normalize, there is a persistence in the elevation of the total cortisol level for a few months after pregnancy. In terms of the treatment of AI during pregnancy, so hydrocortisone is the glucocorticoid of choice because it is metabolized by 11-beta HSD2. So patients who are trying to conceive and in their first trimester of pregnancy, I typically have them just maintained on a physiologic dose of hydrocortisone, like 10 milligrams in the morning, 5 in the afternoon. And then one common approach is to increase the hydrocortisone dose by about 20 to 40%, starting in the second or third trimester to mimic that hypercortisolemia and natural increase in the free cortisol levels during the second half of pregnancy. My pregnant patients with AI, I monitor them at least once a trimester, and I'm looking for signs of under or over glucocorticoid replacement, including monitoring their weight, blood pressure, glycemic control, again, at least once every trimester. For patients with primary AI, the fludrocortisone dose requirements are more variable because progesterone has an anti-mineralocorticoid effect. So the fludrocortisone dose may need to be increased, although sometimes because you're also increasing hydrocortisone, that may be sufficient to cover it as well. Just as in non-pregnant patients, I'm following blood pressure and serum electrolytes to judge the fludrocortisone dose in addition to the presence or absence of edema. You can't follow plasma renin levels in pregnancy because pregnancy itself increases the renin concentrations. For active labor and delivery, I recommend stress dose glucocorticoids to my OB colleagues. And then after delivery, hydrocortisone can be quickly tapered back to pre-pregnancy doses within 2 to 4 days. And the great news for these women is that with good glucocorticoid and mineralocorticoid replacement, we can expect good pregnancy outcomes for the mom and baby. So the last case number 5, is a 41-year-old female, G1P1, with a past medical history of lymphocytic hypophysitis in her prior pregnancy, which was complicated by central adrenal insufficiency and central hypothyroidism, and she was presenting to me for follow-up. Her lymphocytic hypophysitis was, again, diagnosed during her first pregnancy when she presented during the third trimester with headaches, but the diagnosis was unfortunately not made until postpartum when she developed vision changes. In terms of the presentation of lymphocytic hypophysitis, this is pretty common, as about half of cases present during pregnancy, most commonly during the third trimester, and half of the cases present postpartum, most frequently in the first month after delivery. And cases that initially present in pregnancy can also worsen postpartum. And headache and vision changes are the most common. So she was initially seen at an outside hospital where she presented at 38 weeks gestation with headache. And this is her MRI at the time. It was non-contrast, of course, because she was pregnant. And they reported a prominence of the pituitary gland here, extending into the suprasellar region to just below the optic chiasm with no evidence of hemorrhage. Unfortunately, no diagnosis was made at that time, and she was followed conservatively and fortunately had an uncomplicated delivery of a healthy baby girl 2 weeks later. But then 4 weeks postpartum, in addition to the headaches, which didn't resolve, and she had been ruled out for preeclampsia, both at 38 weeks gestation and then postpartum, she then developed blurry vision and saw an ophthalmologist who found that she had bitemporal hemianopsia on visual field testing and rightly ordered a pituitary MRI. And this MRI, 4 weeks postpartum, you can see a 1.8 by 1.2 centimeter enhancing mass within the cella that did exert mass effect on the optic chiasm. She was, this again was at an outside facility, and at the time the differential diagnosis was pituitary adenoma, lymphocytic hypophysitis, or Sheehan syndrome, although Sheehan seemed less likely as she had an uncomplicated delivery, and typically Sheehan's is seen when you have a complicated delivery with significant blood loss. So she was referred to our clinic, and fortunately for her, by the time that she saw us, her headaches and vision were actually already improving. So my question to the group is, what would you do next in this complicated case?
No thoughts yet. It's challenging.
So we were so happy for her, and she was very happy as well that her headaches and vision were improving. And in some respects, that made our jobs a lot easier. We did, of course, do pituitary hormone testing. I think by the time we saw her, she was about 6 weeks postpartum or so, but her 8 a.m. cortisol was clearly diagnostic of adrenal insufficiency, despite the fact that she would still have had elevated CBG levels at that point postpartum. And she had an inappropriately normal ACTH diagnosing central AI. She also had evidence of central hypothyroidism, notably had a low prolactin level, and had noted that she had not, her milk had not come in. She had not been able to breastfeed her baby, had a mildly low IGF-1, and notably had not had return of menses, although she was only 6 weeks postpartum. So with the central AI, we start and central adrenal, central AI and central hypothyroidism, we started her on prednisone and levothyroxine. We made sure to start the prednisone before we started the levothyroxine because we wanted to avoid precipitating an adrenal crisis, as starting thyroid hormone replacement without adequately treating her adrenal insufficiency could have precipitated that. Because clinically, symptomatically wise, and also on exam, it seemed like her, her headaches and her vision was doing better. We decided to get a repeat pituitary MRI as quick as possible, as well as repeat visual field testing to see if there was potentially an improvement, which would be consistent with her improvement in the symptoms. And 8 weeks postpartum, she had this pituitary MRI. And you can see that there is now some space, a little bit of space between her pituitary and the optic chiasm. And visual field testing at that time did show some improvements in her bitemporal visual field defect. And so we thought that this was fantastic, and then we could continue to monitor conservatively. And you can see here at 12 weeks postpartum, her pituitary had decreased further in size. So this was with conservative management. Her lymphocytic hypophysitis improved on its own. These are complicated cases. There was recently a review last year, I think it was in European Journal of Endocrinology, that was a case series of women with lymphocytic hypophysitis, and reviewed, the options for conservative management, surgery, high-dose glucocorticoids for severe headache or visual compromise. So these cases can be very challenging, but it was just so great for her to have this good outcome. She then, she had followed up with me twice a year. And then 4 years later, she said that she wanted to conceive again, but was going to need IVF because she had developed indeed hypogonadotropic hypogonadism because of the hypophysitis. This was a difficult conversation because she wanted to know whether the hypophysitis was going to recur. And at the time, we just didn't have the data to tell her. The review in EJE last year did report in 13 cases that 2 out of 13 cases there was recurrence of the hypophysitis in the second pregnancy. We didn't have that data for us at the time to help counsel her, but we essentially counseled her that it could come back, but we wouldn't know for certainty, but we would need to monitor her very closely during a second pregnancy. She decided to proceed with the IVF preconception. We switched her from prednisone to hydrocortisone and made sure her levothyroxine was adjusted accordingly, targeting a free T4 in the mid-normal range. She was able to get pregnant with IVF. We saw her in clinic every trimester of pregnancy to assess for adequacy of hormone supplementation and to empirically increase her hydrocortisone by 40% in the third trimester. We also had her do visual field testing every trimester to assess for any potential recurrence of the lymphocytic hypophysitis, and her visual field testing, which had returned to normal after the first pregnancy, remained normal throughout this second pregnancy, which was fantastic. And she had no recurrence of headache. So the lymphocytic hypophysitis did not recur during her second pregnancy. And she received stress dose glucocorticoids for labor and delivery, and her hydrocortisone and levothyroxine were reduced back down to her antepartum doses within a few days postpartum, and she delivered another healthy baby girl. Any questions about that?
Yeah, there's a question about, typically in pregnancy, we increase levothyroxine early on in the first trimester. Do you need to do this with adrenal insufficiency, increase hydrocortisone in the first trimester, or just the second trimester?
Yeah, great question. So the hydrocortisone, I typically only increase it in the second trimester, again, by 20 to 40%. But I am monitoring during the first trimester. And if I'm concerned about any symptoms or signs of glucocorticoid under replacement, then I would probably have a low threshold to increase the hydrocortisone dose. But in my experience with my patients who are pregnant with AI, none of them have required a hydrocortisone dose increase in the first trimester. So I sort of base it. I base my decision on the known physiology that the bioavailable or free cortisol doesn't increase until the second trimester of pregnancy.
And then just a question before, you had mentioned starting glucocorticoid replacement prior to levothyroxine, in whom a patient has both adrenal insufficiency and hypothyroidism to avoid precipitating a crisis. How long do you typically wait to start the levothyroxine?
Oh, that's great. I typically wait 3 days. So I do 3 days of glucocorticoids and then start the levothyroxine, although that may vary a little bit by provider, but I think 3 days is adequate.
And then one question back to the DHEAS discussion. When you're treating patients with DHEA supplementation, is there a goal DHEAS level that you're targeting?
Yeah, I'm just trying to bring it into the normal range. And you do have to be careful about over replacement, even within the normal range, in terms of monitoring. I had a patient who we had to discontinue because she did develop hirsutism, despite, I don't even think it was an overtly high, it was just a high normal DHEA. So the monitoring is a combination of clinical symptom signs and biochemical monitoring.
Thank you.
Great. So that was our last case. So the key points from the talk are to know your cortisol lab assay, as cortisol thresholds for the diagnosis of AI are assay dependent. Consider checking a free cortisol level in addition to a total cortisol level in states of CBG excess or deficiency. Have a high index of suspicion for ICI-induced hypophysitis in a patient who is on anti-CTLA-4 or anti-PD-1 therapy who is unwell. In patients on supraphysiologic exogenous glucocorticoids that are being tapered, symptoms of glucocorticoid withdrawal can be similar to the symptoms of AI. The key strategy for prevention of adrenal emergencies is patient education and early response to potential risks. And strategies to help patients with AI who feel unwell on glucocorticoid or mineralocorticoid replacement include changing the type or dosing of glucocorticoid and considering adding DHEA supplementation in women. And so Karen and I wanted to end with a slide of our favorite places in Boston for those of you who've never been for your future trip to our city. My favorite place in Boston is the Boston Harbor Islands, which are a group of islands that you can access by ferry from downtown Boston. And my favorite one is George's Island, which is the picture down here. It has a cool Civil War era fort called Fort Warren on it, and just a great great day for a ferry ride. Well, not today, but when there's a great day for a ferry ride, go take a ferry ride, have a picnic at the fort, and I enjoy it. I do it every year. Karen, do you want to discuss yours?
Yeah, mine is the Harbor Walk. So this is sort of a newly, I don't know, walk area that the city of Boston actually put in when they started renovating some of the spaces. So it does sort of skirt the city and follows the harbor. I think it's 23 miles in total. So you can walk a long time, take your glucocorticoid doses. And yeah, it's beautiful. It sits along the water. There's, the bottom picture is looking back at the city of Boston from south of Boston. So it's, wherever you start and wherever you end, it's a nice taste of the Boston skyline and areas in it. So it's great.
Great. Dr. Kimmel, do we have any other final questions or comments?
Yes, there's another question about treatment of adrenal insufficiency in pregnancy. So practically, what does a 20 to 40% increase in the dose look like? Do you go from 10 in the morning, 5 in the afternoon to 12.5 and 5 or 12.5 and 7.5?
Yeah, so I've done like 12.5 in the morning and 7.5 in the afternoon, which, is a little annoying in terms of you'd have to cut the pills. But in my most recent patient who was pregnant with AI, that worked really well.
And a question for patients on chronic supraphysiologic doses of glucocorticoids for other reasons, do they need to stress dose on sick days? So for example, if someone's taking prednisone 10 milligrams at baseline, do they need to double their dose when they're ill?
Yeah, they should already be covered because prednisone 10 is a typical sick day dose. That wouldn't be an appropriate dose if they were, critically ill. But prednisone 10 should have them covered. So if they're already on supraphysiologic doses, I typically do not recommend additional stress dosing for minor illnesses.
And multiple comments about how wonderful the talk was. Thank you for delivering it. Very practical. And I believe you will be sharing your slides. I hope that's correct, but multiple requests to have copies of your slides.
Yeah, if that's possible through the course, I would absolutely be happy to do that, Karen. And I think I'm speaking for Karen that we would be happy to do that.
Hi, Doctor. I put an email in your chat that you can upload that PowerPoint file to.
Oh, perfect. Okay. That's great.
We'll get that on the support site.
Wonderful. Well, thank you so much, Dr. Haynes, and thank you to Karen. This was a wonderful, and I agree, very practical talk on a challenging topic. Thank you all so much for your participation and your questions. We hope you all have a great rest of the day.
Thank you so much, everyone. Take care.